Thanks very much, Paula. Before I get started, I just want to say that Jim's talk was fascinating. There's a number of things I took away from it, but one that really resonated with me was this notion of rewarding the routine. We really do have an orientation in our culture to reward crisis management or productivity only. And I think that really was summed up by a bumper sticker that I saw in a car as I was driving here today. It said, "Jesus is coming, look busy." The other thing that struck me in Jim's talk was the fact that you get up and talk about great projects like Partnerships for Health, and he said there'll be a group of naysayers, and he's absolutely right. But what I want to say about this work is, in this room there are many faces of people that participated in this project. If by the end of this panel you find yourself being a naysayer or a barrier producer, please go talk to these people. They have transformed the nature of the care that they are delivering, and I truly believe it's sustainable. And with Jim's message, we've just got to figure out how to scale it up across the province and across the country. So I'm just going to talk very quickly about what we did with these teams. The team structure, basically, the purpose of Partnerships for Health was to improve the care for people with chronic illness, particularly with diabetes, by creating interdisciplinary teams and leveraging information technology to transform the way primary care is delivered. So the teams were comprised of primary care teams, but they partnered with community partners. And a very significant partner in this was the CCAC, who put case managers on every single team that we worked with. The diabetes education programs provided people. There were pharmacists, social workers, all the people that you just saw in the video. There were different types of family practice teams that participated. We had our family health teams, we had community health centers, we had Aboriginal Health Center, as well as solo practices, and they came from both rural and urban settings. What we did was help them figure out how to change their practice. Rather than just doing CME and imparting knowledge to them, we recognize that knowledge is necessary but not sufficient for practice change. So we had to teach them action-oriented ways to work with their patient population and work with their own data. We did that through IHI Breakthrough Learning Collaboratives, which I'll talk a bit more about in a moment. We did it through knowledge transfer days, we did it through web-based curriculum, and we also had 3 practice coaches that worked with all of the teams to keep them motivated and keep them going and help them problem solve the work that they did. We carried it out in 3 different waves. The first wave was done with 3 family health teams. This was sort of like a giant PDSA, and you'll understand what I mean by that in a minute, where we got this interprofessional care, interdisciplinary team thing nailed with these 3 teams, and then we went to wave 2 where we had added 9 more teams, and then in wave 3 we brought on 61 teams who learned in a variety of different modalities. And the recipe for improving their outcomes was based on these 4 menu items. Evidence-based clinical change concepts, which is jargon basically for evidence-based guidelines. They had to have a system change strategy, a way to redesign the way they were delivering care, because as Jim said, bad care is not about bad providers. It's about a system that doesn't allow them to do the care that they were trained to do. So then we have to change the system. We needed a quality improvement methodology, and we used the model for improvement that Jim also mentioned in his presentation. And then, as I said, we had different learning modalities, but the major one was these Breakthrough Series Learning Collaboratives. Let me talk about each recipe a little bit, or each ingredient a little bit. The guidelines were fairly straightforward. They're the Canadian Diabetes Association guidelines that were used with the teams. Our expert faculty, such as Dr. Stewart, Irene Hermiak, and others, helped the teams understand how to implement these evidence-based guidelines in their practice, and so that was the core of good care. Ontario's Chronic Disease and Prevention Management Framework was the system change strategy that we used. It's based on the chronic care model, which was created by Ed Wagner and our colleagues at the McCall Institute out of Seattle, and is being used in a number of provinces across Canada. And the basic tenets of the model is that teams have to actually function as teams. We have to get out of our professional silos and delegate work across the teams. Self-management support needs to be delivered. to patients at every possible encounter to help them do better self-care. There needs to be planned visits rather than the chaotic reactive care that typically goes on in primary care. We need to leverage IT so that we do population-based care and can track subpopulations of patients to target care to those particular patients based on their need and based on disease severity. And then we need to make use of those community partnerships and those community providers like case managers, like the diabetes educators, pharmacists and social workers, and bring them onto the team so that they can work together to transform the way that care is being delivered. The model for improvement was the quality improvement strategy that we used, developed by Associates for Process Improvement. It is a rapid cycle learning or testing methodology that gets us out of the traditional healthcare planning mode, which is basically plan a bit more, put together a steering committee, do some more planning, and then someone says, have you done anything? And then we panic. What we want to do is move away from that incessant planning that moves towards implementation that often isn't successful. And this model allowed the teams to test ideas of change on a very small scale in their practice, one patient at a time, one idea at a time, and they would build on those successive tests until they got to a point where they were ready to implement a change that would transform the way they were delivering care. And then finally, the Learning Collaborative. For waves 1 and 2, they went through a full one-year process where they came together for 3 two-day learning sessions to learn about these models, to learn about evidence-based care, but more importantly, to learn from each other in terms of how they were changing their care. Between the learning sessions, they would go back and they would test ideas of change. The practice coaches would go and help them work on those tests of change. Our IT director would go and help them learn how to pull data from their IT systems so that it would guide improvement for them. And so it was a very intensive action-oriented learning process. In the second year of Partnerships for Health, we did booster or refresher days to keep the teams focused on the quality improvement work and to get it built into the culture of the way they do care. The measurement for improvement was very important. The teams collected data from their EMRs. This was no small feat. This is a very difficult thing to do. And they collected data on a monthly basis. They tracked it on time series run charts so they could see that if they were trying to improve foot care, they could see documented proof that they were increasing the foot care rate. All of the waves, all 3 waves, had to collect data on a monthly basis on 14 diabetes measures. Waves 1 and Waves 2 have been doing it for over 2 years, well, it's almost 3 years now for them. Wave 3 came in at various times, and so they're in various places in terms of their data collection. What's important to recognize is that the data they collected was not data for research. It was data for quality improvement, so it was just good enough data. That it was just good enough to inform them that the changes they were making were resulting in improvement. But to the end of the fact around it, is this really making a difference from a rigorous standpoint? There was a formal evaluation being conducted, and you'll be hearing from Dr. Stewart the results of that evaluation. It was a pre-post analysis of the work done in Partnerships for Health. It involved chart reviews, provider surveys, patient interviews, patient focus groups, and staff interviews. Waves 1 and Wave 2 were the 2 groups that were focused on in terms of the chart review, but there was also a pre-post analysis done on all the Wave 3 teams, and as I say, you'll hear more about that analysis. I think the important thing to remember about Partnerships for Health is while it was only a 3-year project, and by the way, it was funded by the Ministry of Finance, its intent was that the teams would leave this with transforming their care and continuing to do care in a new way and a new way of business. And I guarantee you, if you go around and talk to some of these teams, they had done just that, and they have improved their care, as you saw in the video. So with that, I will hand it off to Dr. Sean Blaine, who had the pleasure of going through Partnerships for Health. He's done an incredible amount of quality improvement work. And do you want to say anything, or should I just hand it back to Paula, I guess? Thanks.
Thanks very much, Paula. I guess we're going to move this. Let's see here. There we go. I really am humbled to be here. It's a fabulous turnout, great conference. The keynote address was amazing and inspiring. But I stand before you as someone who shamelessly will say to you that I have the best job in the world. I'm a family physician in Ontario, and I have started my practice in the late 90s, but the past 5 years, I and my patients have been on a journey of absolute transformation. We started with going from fee-for-service to a capitation model. Then we went from the paper charts to the EMR. Then we introduced other disciplines into our team. And then we learned and developed some of the business strategies to work together as a team. And now we're tackling the most difficult item of all, and that is translating all of that into quality healthcare for our patients. Star Family Health Team is located right here in Stratford and the neighboring community of Tavistock. We're spread out among 3 different clinics. And what I'm going to talk to you today very briefly is what we learned from the P4H process, what were some of the measurable and perhaps more importantly non-measurable outcomes of this. What were the barriers, because it's really only through the challenges that we're going to learn and grow and evolve. And where do we go from here? The team itself is now up to about 17,000 patients. 900 of them are confirmed diabetic patients, and there's about another 1,300 or 1,400 waiting in the wings. And in fact, my team has an application in to the Public Health Agency of Canada to do work in the pre-diabetes screening area, and hopefully we'll be able to work on that. But today's talk is really about diabetes and how the Partnerships for Health helped us tackle that as a chronic disease and a model for tackling the host of other chronic diseases that we face on a daily basis. The first thing I'd like to say is the key is to harness the power of the team. We've now got a family health team with a pharmacist, a social worker. You've got to bring them into the fold, and you have to relinquish control of your patients and allow these other professionals to do their job. P4H allowed us to bring in other providers from other agencies, especially CCAC, the Diabetic Education Center, and that was tremendous in allowing us to access those important resources that many of us were completely ignorant of. The other thing you have to do is you have to expand practitioners' roles so that they're practicing at their full scope of practice. Because there's nothing worse than having a skilled healthcare worker only doing part of what they could be doing. It all takes time. And it's very frustrating because we have to sit down, we have to plan this out, we have to have meetings, and all of that takes time away from the most important thing, which is really just seeing patients. That's all you're supposed to do is see patients, because that really is what work is all about. But we have to learn that the time that you took to meet and talk about this stuff was actually important. And what we hope to do is transfer this to other conditions. Could you hand me my water, please? It's a little parched up here. So when I say harness the power of the team, I talk about the fact that the nurses are now regularly doing foot checks. And I have to admit, when I was just seeing diabetics myself, 3, 4, 5 years ago, I really wasn't doing proper foot checks and taking the time to do it. Well, this patient that you see here didn't know that they had that ulcer developing on their toe. And there's no research that you're going to hear today from Dr. Harris or anyone else that's going to measure the benefit that identifying that ulcer had. But these benefits are happening right now, and it's important that we kind of sing these praises of the system because it's actually making an impact right now. Another big area is data management. This is a big ticket item. For us, what we had to learn to do was to agree on terminology. You have to have consistency in documentation in the electronic chart. It's difficult when you're dealing with 3 different clinics, 11 different physicians and other providers. So we picked some main ICD-9 codes. We looked at the relevant comorbidities. You've got to record it properly, but then you need the people to track the data, clean it, trend it, and present it. And for P4H, that was looking at 14 indicators, but there are innumerable other indicators that could be selected. We were very fortunate to capitalize on the LIN strategy of eHealth, namely the Spire that you heard about earlier. We now get our data from the Stratford HPHI hospital directly into so Meditech data goes directly into Practice Solutions, which we're using in our primary care office. And then our team coordinator takes that data, puts it into an Excel spreadsheet, and presents it to us. Of course, the problem is you have to look at the data then too. And that's a challenge because you're not used to looking at your patient as a population. So really we need to change the way you think. And normally, family doctor, you go into work and okay, well the patients start coming in at 9, you see patients right till 12, if you're lucky you get lunch, and then you see patients right till 5. Well, those days are over, okay? A lot of this is looking at your patients as a population. It's statistical, you need epidemiology support, and you need the time to look at the data to see your performance and how things are going and what you can do to change. So here's some data from my practice that I'm going to share with you. This is ministry data specific to me. All family physicians got these charts. In the top left-hand corner, you'll see that for the indicator that hemoglobin A1C was done in the previous 6 months, my practice specifically was 76% of my diabetics were getting that test done. The next column is the comparison of that to the family doctors in the LIN, and the next column is how I compare it to the provincial average family doctor. And I looked at this data when it came to me and I thought, wow, I'm doing pretty good, this is great. I'm above average. The next column over, the next slide over, so again at the top on the right, that indicator is looking at how many of my patients who have diabetes had an LDL level done within the previous year. My data shows for my practice 83%. Again, I'm doing better than the LIN and better than the province. I'm feeling pretty good. Well, so happens that we formed a partnership with some former colleagues of mine at U of T at ISIS, who we basically send them all of our EMR data securely, because ISIS is a provincial agency, and they crunch all the numbers. And they kind of did a similar exercise. They sent me data, but in a different format. If you look at the second bar, you'll see that that 75% there again is exact. So that's A1C tested in the previous 6 months. So the comforting thing, first of all, was that ISIS data and the ministry data were bang on, okay? So 75% of my practice with diabetes had an A1C done in the previous 6 months. But in this case, ISIS was comparing me to the top 10% of family doctors in the province. And they reached 85%. And so when presented this way, I'm doing pretty good, but I'm not doing as good as I could be doing. If you look at the other reading, which is LDL, you'll see that I was third from the bottom. The 85%, again, correlates pretty well with the 83 of the ministry data. I was doing pretty good in that regard. But if you look at reaching the target LDL of less than 2, I only got 31% there. And so after this is June of 2010, right in the middle of the Partnerships for Health process, they send me the data now 6 months later in December, that 31% of patients, target LDL less than 2, moved up to 47%. Okay? So for me in my own practice, I see change, but again, I'm still seeing with those blank spaces, there's a lot more that I could be doing to get into the top 10%. I'm going to really whip through these last slides because I'm getting the warning buzzers here. Advanced access. If you talk about quality of care, primary care, this to me has been absolutely pivotal. We now have adopted this in our practice. It is amazing, it is wonderful, and if your doctor is not doing it, ask them why, because it is amazing. Gone are the days, in my opinion, of when you call your doctor and you want to book a physical and they say, well, how does August 23rd sound? Or if you call and say, well, I've had a little bit of abdominal pain for a month or two and I just think I should check it out. And they say, well, okay, well, we'll see you May 31st. Those days are gone, okay? And if your doctor's not practicing, they don't know what they're missing. I get out of work earlier, the patients love it, and my front office staff love it because they don't have to triage anymore. Problem is you have to do advanced access while doing chronic disease management too, and that's tricky. Mike alluded to self-management. I'll only say here that we really need to develop a new skill, which is essentially health coaching. We have to figure out what's important to the patients. What is going to motivate them to make the change? What are the incentives? What are the things that they find important? And so the old acronym of RIC, which I learning all these new acronyms, PDSA and RIC. So how ready are you to change? How important is it for you to change? How confident are you that you will be able to change? And do you have the knowledge to do it? Finally, my last slide is talking about CCAC, and it's a nice segue into the next speaker. You know, I have really enjoyed the relationships that I've developed with some of the people at CCAC, and I highlight the word relationships because that's the only way it works. Connie's in the audience. Connie and I work very closely together, looking at the list of my patients who are on the CCAC list. And when we sat down for the first time, I looked at that and said, I never knew they were on the CCAC list. I never knew that they were getting services from you folks. So we sat down, we talked about cases, and you know, some of the barriers to overcome, like we would have regular meetings, and then all of a sudden I stopped seeing Connie, and I saw her at a meeting. I said, well, why haven't you come back? She said, well, I can't get through your front staff. They won't let me in to talk to you. So we got around that by exchanging cell phone numbers and emails. And really the point here I want to make is the importance of personal relationships. That's what's key when you're dealing with these outside agencies. If you're getting some nondescript facts from some healthcare thing about a patient, it really is nothing compared to picking up the phone and talking to Connie about Bill. So harness the power of the team. We need the data management support. It has to be funded, and it's been like pulling strings to try to get this stuff. We're way behind the rest of the world, way behind the UK in funding for IT in healthcare. We have to rethink the way we practice and continue to expand the circle of care. And so for my part, I give a big thank you to Partnerships for Health for allowing my patients and I and our team to kind of share in this journey, and we're really excited about the way things are going. Thank you.
Thank you, Paula. It's been a very transformative experience for me to be involved in this, and for our entire CCAC team and organization. And maybe bold words as the title, around a whole new era, but maybe you caught a glimpse from Sean that in fact that's not overstating it, that we did go from a black hole at the end of a fax and a kind of paper-based periodic involvement after the downward spiral of diabetes had hit our clients. They were getting out of hospital, and finally at that 11th hour, we get involved to do the SAVE. And we went from that to instead, because of Connie and other case managers in this project like her, being an integrated member of the team on site with a relationship, involved proactively as a care connector, making sure all of the services were in place that those clients with diabetes needed. So many, before this project started, certainly it was the fact that most of our referrals were coming out of hospital and only a very small number from primary care, and often then wound care after a hospital episode for clients with diabetes. And what we have then understood is that we weren't focused on health promotion. We weren't focused on self-management. The communication with us was far too complex and confusing. As I said, the black hole, and there wasn't nearly enough sharing of information. We weren't used to our full potential at all. In fact, it was interesting at the beginning of this project when the CCAC case managers were there learning, as part of the learning collaboratives Mike referred to, sometimes the physicians in those earliest moments would sort of ask, why is the CCAC even here as part of the potential team, having no idea how much support we could indeed provide to them and to their patients. So what did we do about that? Well, first of all, our dedication of case managers to forming that relationship, to being on site as a member of the team, whether that's once a week, whether it's several times a week, whether it's once every several weeks, whatever that team needed, our case manager was there on site creating that relationship. They were there side by side on all of the learning sessions, whether that was on a clinical focus around diabetes best practices or around quality improvement. So our case managers involved in this project are now experts in not only the care of those for diabetes and the resources available in the community to support them, but also on PSA and on quality improvement and on the sort of quality improvement methodology, a significant capacity improvement in our organization. They attended all of the improvement sessions that took place so that they were there figuring out how to change this and how to change that and how to test this, and this might work better and this might work better. And then as the physicians and teams began to create things like diabetes, holding more case conferences, doing shared care planning, and figuring out better how to do quick insulin starts at home in connection with the diabetes educators, all of that flowed very smoothly from that upfront role clarity and partnering and relationship building. We developed common screening tools so that the physician's team would know you ask these 3 or 4 or 5 questions, yes, 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 make sure that the case manager gets involved. We developed links with community resources that were much stronger and more comprehensive than existed before this program took place. And we also learned all of the self-management tools and processes and ways of being, and passed those on in all of our experiences and interactions with the patients. We also had a significant IT revolution, and again went from that fax machine to instead, in the most advanced practices, physicians being able to do a referral to us straight out of their electronic health record at the push of a button, and likewise electronic uplinks from our significant electronic health record called CRIS. It's the common system across all CCACs in the province, and the upfeed of that data into the physicians' offices and preventing that paper exchange. And in some sites, we even were able to work out an electronic summary out of the hospital discharge process to forward to the physician, in addition to the usual exchanges that might be in place between hospital and physicians. So this was a mammoth improvement machine, Jim, for us. This was at scale in the sense of 30 case managers linked with 73 physicians, and you'll see all of the extensive number of other players that had to do this through our organization, but the one that stands out for me is 117 PDSAs, meaning 117 tests for change and implementation of change that is taking us to the outcomes. And so what are those outcomes? An increased understanding of the CCAC role. I can't begin to understand the sort of pebble in the pond impact from that result. But one small measure is that as we interviewed and surveyed physicians before, during, and after this project, at the beginning, only 33% were satisfied with the involvement and communication of the CCAC, and now we have 100% of physicians saying that the case manager improves their patient care. In a million years, I would never have imagined getting to that result in just a few short years. We have much improved screening and early identification and better care coordination. How can I say that? Well, we've had more than a 25% increase in referrals to us and in turn to the other community organizations that we bring in through our Care Connector or system navigation role. And we have been able to see through our CRIS system, our electronic health record, a 5% annual decrease in our clients with diabetes who have been part of this project. We pulled those out separate from our general population, and we've been able to track a 5% annual reduction in their attendances at hospital or at the emergency room. We also have documented increased use of clinical guidelines and indicators by our team, as well as other improved clinical outcomes that you'll hear more about from Dr. Harris.
Thanks, Paula, and thanks to all of the presenters today. Hopefully you're going to leave today with the impression that this was a very successful project and initiative here in the Southwest LHIN, but it really isn't enough. Sandra asked the question, what about those other 600 family practice physicians and the patients that are served by those individuals, and how do we ensure that all benefit from the kind of care that the teams that were involved are now providing to their patients within the Southwest LHIN? So it is hard work to do this, but it's even harder to think about that spread and sustainability. As we went through the project, there were a lot of challenges in the project phase that needed to be addressed in order to be successful with this initiative. Some of those, one of the key ones was actually recruiting the family practice physicians to be a part of this initiative. And we had significant incentives that we were able to offer because of the funding from the Ministry of Finance and the fact that this was a project. We set our goal at up to 100 family practices joining Partnerships for Health, and we applauded our success in achieving 73 practices entering into the project. But there's many other practices out there across our land to be recruited and engaged in this kind of quality improvement effort. Some of the other challenges that we faced were about aligning with other things that were happening. And Jim talked today about joining up initiatives, and I think that's strategically one of the key challenges that we face within our LHIN and across the province. There's lots of activity out there, sometimes disjointed, disconnected, duplicating effort. And so we need to make sure we weren't creating that same kind of duplication or confusion through Partnerships for Health. Many of you may be aware of the QUIP initiative provincially, supporting family health teams largely with quality improvement initiatives. So we needed to work really closely with our provincial partners in QUIP to ensure alignment with the processes that we undertook through Partnerships for Health. And actually, because of Mike Hindmarsh's connection with the QUIP initiative, we were able to really create a parallel and complementary process and work through those issues, I think, with our teams going forward. The CCAC role, as you heard, was key. And at the outset of the project, Sandra and her team made the commitment to create that linkage with primary care and realign their processes and structures in order to do that. But that's a challenge when we have other financial challenges and pressures out there within our system. The alignment with the diabetic education centers was also key, and they were not incentivized provincially to be a part of something like Partnerships for Health. The measures that they're evaluated on weren't necessarily the kinds of measures that we would want them to be looking at when we think about the role and the processes within Partnerships for Health. So creating those linkages were challenging as well. We had also at the outset endeavored to link very closely with our mental health and addictions partners, recognizing that oftentimes issues of depression and other mental illness can impact people's issues related to chronic disease management. And although we were able to create some linkages, our mental health providers weren't really incentivized to be part of this, and they didn't necessarily have the capacity to join in this initiative the way we would have liked going forward. And recognizing that within sectors there's lots of opportunities for quality improvement that need to be addressed. So asking sectors to work together is raising it up another level. But I really would submit that through this process, it was about quality improvement, but it was also about integration and creating that integrated care team across the different partners that were involved. Despite these challenges, there were lots of success factors that helped us achieve the results that you've heard about today. So strong leadership and physician engagement. So folks like Sean and his colleagues that were part of this project really set the stage for change within their practices and working with their teams. We did provide significant support to the primary care teams, and you've heard a bit about that as it related to information management particularly. The use of data is really key when we're looking at quality improvement initiatives, and it was hard work for practices to access that data and view it in a way that helped them look at the management of a population. The quality improvement infrastructure was a key success factor. The coaches that you heard about, the website that was developed for the teams to report their data on and to catalog their PDSAs, those were all tools that helped the teams to be successful with their quality improvement initiatives. The CCAC working across all the teams was another key enabler, attaching that case management function to the primary care practices, as well as the self-management strategy which the CCAC is involved in. They were already working with us on some of those strategies, and they were able to help spread that knowledge across to all of the partner organizations. And then Mike talked about those action-oriented learning sessions. Those were key. So that whole approach to quality improvement, it does need to be driven at the ground level with the providers involved and engaged in the improvement activities. So when we start to think about how do we move forward to spread and sustain this work, Jim's presentation this morning really resonates because all of the elements that he talked about are the elements that we need to support at a system level within the Southwest. One of the things that we've been working on over the last year is the creation of what we're calling the Quality and Process Improvement Program. We funded that initiative through Aging at Home, and the CCAC is the host organization for that program. And what we're doing with that program is trying to create an infrastructure or a resource base to support quality improvement. So that program now has 2 priority initiatives that they're going to be working with the Southwest LHIN, us, you, all of us together. One is spread and sustainability of partnership for health, and the second is access to care, which you've already heard some about today. So within that resource, we're looking to have practice and improvement coaches. We want to attach IAM improvement coaches as well, or coaching resources. That organization will help to support learning collaboratives related to quality improvement initiatives. And they are now hosting our newly launched Quest for Quality website, which is a transformation of what was originally the Partnerships for Health website. So that will be an electronic resource at www.questforquality.ca that people can go to for information on quality improvement methodology, and also be a way that we'll join things up across our LHIN related to quality improvement. And then as well, they have resource for analytical support. I have to say, it's a small unit, if you will, or a small program that we've created. So we're also looking at how do we augment those resources to support these various initiatives. And just yesterday, the Southwest LHIN Board of Directors approved both the access to care and the spread and sustainability of partnerships for health as priorities for investment for one-time dollars going forward, to continue to put resources to supporting the infrastructure for quality improvement within the Southwest LHIN. So as we continue to move forward, we need to continue to support the development of those integrated care teams, focusing on best practice. We started with diabetes because the guidelines for diabetes care were clear, but hopefully you've heard that already the results are reaching beyond diabetes care as teams are working differently together, differently with their partners in the community. It's not just impacting those with diabetes, it starts to impact and benefit other patients that are treated by those practices. The CCAC is looking at how they spread this model out across the LHIN, and although it's challenging when we look at fiscal constraints, we're challenged to do this work in our LHIN so that we are able to create these kinds of partnerships with primary care across the board within the Southwest. We also are looking at furthering our approach around self-management. So we've done training to providers around self-management, and through the further implementation of the self-management strategy, we're implementing the Stanford program within our LHIN and making that accessible to individuals with chronic diseases. And there's a greater emphasis on system-wide performance measures. And so the Regional Coordination Center for Diabetes, which is also hosted by the CCAC and our Southwest LHIN, we'll be really working closely with the Quality and Process Improvement Program so that we continue to look at measurement and accountability for results as we move forward. Our self-management strategy, the Regional Coordination Center, these are all initiatives that have grown up out of different initiatives within the Southwest, but we're able to start joining these things together, and I think that's a key message that resonated for me in Jim's presentation together. Oftentimes it looks like we've got a lot of things on the go, and people don't always see how they connect up. But what we're trying to do is link all of these things together to support the quality improvement initiatives within the Southwest LHIN. And the last comment that I'll make is again around primary care engagement. So as I said, one of the challenges was recruiting those primary care teams into the Partnerships for Health initiative. We need to continue to partner with primary care within the Southwest LHIN. And through the leadership of Dr. Rob Annis, he's created a primary care network, and he's bringing together primary care practitioners from across the geography of the Southwest, and they're engaging around important regional initiatives here in our LHIN. We've had the opportunity to attend the network meetings to talk about initiatives like Partnerships for Health, or work that we're doing, for example, related to hips and knees. And Rob is certainly engaging that group around his role with the London Regional Cancer Program. Our vision is to continue to build on this network, citing local leaders within primary care as key members of the network who will continue to come together and reach out to other primary care practitioners so that we can create that greater coordination amongst our primary care partners. Most of you, hopefully, are familiar with the Integrated Health Service Plan and blueprint of the LHIN, and certainly strengthening and improving access to primary care was one of our first priorities, and we've continued to build on that with our emphasis on chronic disease prevention and management. And this initiative is truly one that demonstrates how you can be successful in achieving those goals by working together within our LHIN. And so I thank all of the individuals who have participated in Partnerships for Health, and congratulate everybody on the hard work that went into this initiative, and look forward for the future work that we have as we continue to spread and sustain Partnerships for Health within our LHIN.